Hi, my name is Terry Mamounas. I'm a breast surgical oncologist. I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute here in Orlando, Florida. Right, so the question is, what potential donor sites are used in breast reconstruction, and what site has the best cosmetic and surgical outcomes? So there are several potential donor sites for autologous tissue for breast reconstruction. And traditionally, when this all started, autologous breast reconstruction was performed with abdominal pedicle flaps, the so-called Trump flaps, and also latissimus dorsi flaps, in which cases these were myocutaneous flaps that actually kept their original blood supply intact, and they were rotated to fit the mastectomy defect. But because they were rotated and the edge of the flap had minimal blood supply because it was coming from the other side, sometimes we had problems at the edge of the flap in terms of fat necrosis. And of course, the field then advanced with the advent of microvascular surgery, and then free flaps have now become the standard approach for autologous breast reconstruction. Now, the most commonly used autologous tissue flap is the deep inferior epigastric flap, or also called DIP flap, that does not include the removal of any part of the rectus muscle. And that's a big advantage of this flap because there's intact musculature left behind. So this flap in appropriate candidates usually provides enough tissue for bilateral breast reconstruction. That's another advantage. And that's the most commonly used flap that actually gives us probably the best cosmetic result. Now, other flaps, such as the latissimus dorsi flaps, are utilized, but they usually don't provide enough autologous tissue. And typically, they require also the presence of an implant to fill the defect. And these flaps sometimes are used for patients who desire implant reconstruction, but whose treatment also involves the use of radiotherapy because they used to further protect the implant from the effects of radiation that increases the complications. And there are some other autologous flaps used, such as, for example, the gluteal flaps and the gracilis flaps that are used more uncommonly, but sometimes they're used in patients that don't have the ability to get an abdominal DIP flap, either because they have prior surgery that affected the vasculature in the area, or because they have very little tissue in the abdomen to consider enough for reconstruction. So, for example, the superior gluteal artery perforator flap, or also called S-gap flap, they use tissue from the top of the buttocks to fill the mastectomy defect. And again, this is used for patients that are not good candidates for a DIP flap. And another flap that is not as commonly used for breast reconstruction, but is commonly used for other reconstructions, is a gracilis flap, which essentially is a myocutaneous flap for breast reconstruction, but usually just the muscle is removed for other reconstructions in the head or neck. But for breast, it can be used as a myocutaneous flap that can easily be formatted in a way to actually fill the mastectomy defect. So very uncommonly, but this is another option for breast reconstruction. But the best results and the most common reconstruction is performed, autologous reconstruction is performed with a DIP flap.